This conference will now be recorded.
Good morning, everyone. I'm Dr. Praneeth, General Surgery Assistant Professor. Let us discuss about today's topic, shock. Ah, how are you? Okay, these are the headings we will be discussing today. That is the definition, pathophysiology, classification, resuscitation, and fluid therapy. Remember these people. This is very important topic at your standards. Coming to definition of shock, this is very important. Remember, definition of shock. It is a state of low tissue perfusion which is insufficient for normal cellular respiration and as well as metabolism. Remember, shock is nothing but a state of a low tissue perfusion where the perfusion to the tissue is less. How much it is less is which is insufficient for the normal cellular respiration as well as metabolism. Coming to pathophysiology. So remember, though there are many causes of shock, the basic pathophysiology is the same. So basic pathophysiology at the end it will leads to inadequate perfusion. So what will happen if there is inadequate perfusion? It will cause cellular hypoxia. If there is cellular hypoxia, it will leads to energy deficit. This will leads to lactic acid accumulation and fall in pH because of whenever there is an oxygen, it will leads to aerobic metabolism. If there is inadequate perfusion, there will be inadequate oxygen. So there will be cell hypoxia. When there is energy deficit, there is a lack of aerobic metabolism, which our own cell will convert into anaerobic metabolism. And the end product of anaerobic metabolism is nothing but the lactic acid accumulation. So when there is more lactic acid accumulation, which will occur in anaerobic metabolism, if there is more acid, the pH will be obviously less. So there will be fall in pH. So this will leads to metabolic acidosis. What will happen because of metabolic acidosis? Because of metabolic acidosis, there will be vasoconstriction. If there is vasoconstriction, there will be failure of precapillary sphincters, which will lead to peripheral pooling of blood. Okay, fine. After metabolic acidosis, what will happen? There will be membrane disruption and failure of sodium pump. What will happen if there is a failure of sodium pump? Intracellular lysozymes release digestive enzymes. These digestive enzymes will efflux the potassium and influx of sodium and water. So these toxic substances enter the circulation. Then capillary endothelium gets damaged, leading to destruction, dysfunction, and cell death. This is nothing but the pathophysiology of the shock. Remember, very important. Main concept is of any type of shock is this. This is the same pathophysiology for any type of shock. It's a common pathophysiology. Very important is this: inadequate perfusion, hypoxia, energy deficit, then anaerobic metabolism because of this lactic acid accumulation, metabolic acidosis, cell membrane disruption, lysosomal release, endothelial damage. It leads to cell death. Next, what is happening at the cellular level? So at the cellular level, what is happening? What I have discussed previously, tissue decreases in result of oxygen supply. Because of decrease in oxygen supply, it will shift from aerobic metabolism to anaerobic metabolism, which will lead to lactic acid accumulation, which will lead to metabolic acidosis. Okay, see, this is the here. What I told you, it is written here. As anaerobic metabolism increases, for which the end product is lactic acid, which results in more production of it. As lactic acid accumulation increases, it will lead to metabolic acidosis, and glucose within the cell gets exhausted, results in sodium potassium pump failure. Okay, what is happening later? Lysosomes release auto digestive enzymes, which will lead to cell lysis. What will happen? There will be intracellular content will be released into the blood. That is nothing but efflux of potassium into the blood and influx of sodium and water, leading to edema, leading to potassium losses. Then, what are the changes that is occurring at microvascular level? See, yeah, at microvascular level, as tissue ischemia increases, which will release in acidosis, that is metabolic acidosis. This will activate the complement and prime neutrophil, which results in generation of oxygen-free radicals. These oxygen-free radicals causes injury to the capillary endothelial cells. This destruction of endothelial cells because of oxygen-free radicals results in leakage, leading to tissue edema, which further increases the cellular hypertrophy. Coming to the pathophysiology, those are the changes occurring at the systemic level. That is CNS, CVS, respiratory system, renal system, endocrine system. Okay. Coming to CVS, as preload and afterload decreases, it stimulates baroreceptors. So what will happen if there is a stimulation of baroreceptors? If there is stimulation of baroreceptors, it increases the sympathetic activity. So increase in sympathetic activity obviously leads to increase in the catecholamines in the circulation. More the catecholamines, there will be increase in pulse rate, that is tachycardia and vasoconstriction. Coming to respiratory system, so increase in metabolic acidosis results in compensatory respiratory alkalosis. So by increasing respiratory rate and minute ventilation. So coming to renal system. So what are the changes that occurs in the renal system? If there is vasoconstriction, peripheral vasoconstriction and significant vasoconstriction because of catecholamines, what will happen? This will decrease the perfusion pressure, results in decrease in glomerular filtration rate. So if there is decrease in glomerular filtration rate, at the end what will happen? It decreases the urine output. If there is decrease in the urine output, it will stimulate renin-angiotensin-aldosterone mechanism. This results in further vasoconstriction, increase in sodium and water absorption. Coming to the changes that occur at the endocrine level. So what will happen? There will be increase in vasopressin. So this will lead to vasoconstriction and water reabsorption. And there will be increase in cortisol, which will also increase in sodium and water reabsorption. See, remember, these are the pathophysiological changes at cellular level, at microvascular level, at systemic level, that is CVS, respiratory system, renal system, endocrine system. So everything, the same common concept is, at the end, what is happening is there will be decreased perfusion to the cell. That is why it is called as shock. Coming to ischemia reperfusion syndrome. What is ischemia reperfusion syndrome? It is nothing but when a patient has got an insult, that is some viral trauma or some other thing, when patient undergoes into ischemia. So there is an episode of ischemia. So what is happening in this syndrome is there the patient is having an episode of ischemia. Patient underwent treatment or he doesn't underwent treatment. So there will be an episode of reperfusion. So after an ischemic episode, patient will have an reperfusion episode. So what are the changes that occur in the patient after this reperfusion episode because of the previous ischemia is nothing but the ischemia reperfusion syndrome. So coming here, what is happening in a period of ischemia? So in this syndrome, see, remember ischemia reperfusion syndrome. So when an episode of ischemia is there, the changes occurring in the body is nothing but, I told you previously, acid and potassium accumulation leading to myocardial depression and vascular dilatation, which further aggregates hypertension. This is the thing happening. So what is happening? This acid and potassium is accumulated within the cell. So when there is reperfusion, so you are recovering the cell. So what will happen? This accumulated potassium and acid is released into the peripheral circulation. This will cause end organ damage. Yeah, see, remember, increase in the cellular humoral element reaches back to the circulation, further damage endothelium. This is nothing but a ischemia and reperfusion syndrome. Very, very important classification of shock. Remember, H code. This is a mnemonic H code. Classification of shock. The most common type of shock is hypovolemic shock. Encountered in surgical practice or medical practice, the most common cause for shock is hypovolemic shock. First all, cardiogenic shock, obstructive shock, distributive shock, and endocrine shock. Briefly, let us discuss about each type of shock. So coming to hypovolemic shock. Hypovolemic shock is nothing but it is due to decrease in the circulatory volume. So it is the most common form of shock. First, if you don't know the type of shock, you have to consider it to be as a hypovolemic shock, and we have to further classify whether it is this hypovolemia is because of hemorrhagic shock or not hemorrhagic shock. This is not necessary for you. So yeah, what are the causes of hemorrhagic shock? Hemorrhagic cause because of loss of blood. It could be because of surgery. It could be because of trauma. Then non-hemorrhagic causes of shock, that is poor fluid intake, excess fluid loss due to vomiting or diarrhea, excess loss through urine. Third spacing is nothing but accumulation of the fluids in the peritoneal cavity, pleural cavity. This is or pericardial cavity. This is called as third spacing. Hemorrhaging, yes, hemorrhage should be recognized immediately to minimize duration of shock and to avoid death. It is treated mainly by arresting bleeding other than blood transfusion and fluid infusion. Remember, this is very important statement. Remember, if people will think in case of hemorrhagic shock, because there is a loss of blood, you people will be thinking you have to go for blood transfusion. It is wrong. The first and primary step in management of hemorrhagic shock is arresting the bleeding by further means. Later, plan for stabilization of the patient by infusing blood transfusion and fluid infusion. Coming to pathophysiology, tissue trauma and hypovolemic shock leads to development of endogenous coagulopathy called as acute traumatic coagulopathy, ATC. As bleeding continues with resuscitation by IV fluids, it will result in dilution of coagulative factors, result in dilutional coagulopathy, which will further increase hemorrhage. So initially, ideal fluid, if we have to plan for replacement, ideal fluid of replacement in hemorrhagic shock is blood, and it's not IV fluid, because high resuscitation with IV fluids leads to dilution coagulopathy, leading to further bleeding. And other types of hemorrhages are concealed hemorrhage, revealed hemorrhage. The name itself suggests revealed hemorrhage is where you can see it from the outside. Concealed hemorrhage is where it will be inside. See, revealed hemorrhage, where hemorrhage can be witnessed from an open arterial wound or massive hematemesis from duodenal ulcer. This is nothing but a revealed hemorrhage. It can be easily assessed as the end organ with error is noticed or visible. Whereas concealed hemorrhage, the name suggests it is concealed. The hemorrhage is contained within the cavity. It can be within the chest cavity, peritoneal cavity, or pelvis. Example: occult gastrointestinal bleeding, ruptured aortic aneurysm. Next, other type of classification is primary hemorrhage, reactionary hemorrhage, secondary hemorrhage. What is primary hemorrhage? Hemorrhage occurring immediately during an injury or surgery is primary hemorrhage. Reactionary hemorrhage, delayed hemorrhage within 24 hours due to dislodgement of clot by resuscitation, normalization of blood pressure, or it may be because of slippage of ligature. It is reactionary hemorrhage. Next is secondary hemorrhage. Secondary hemorrhage is usually occurs 7 to 14 days after injury. This occurs because of sloughing of vessel wall, which is occurring due to precipitated by infection, pressure necrosis, or malignancy. So remember, very important. These definitions. Primary hemorrhage usually occurs immediately due to an injury. Within 24 hours, reactionary hemorrhage. 7 to 14 days, secondary hemorrhage. Reactionary hemorrhage causes are slippage of ligature. Secondary hemorrhage is because of sloughing of vessel wall. These are the important differences and important definitions you must know. Surgical hemorrhage. This is direct injury and can be controlled surgically. Non-surgical hemorrhage, general wounds from all raw surface due to coagulopathy, can be managed by conservative management. Doesn't require surgical management. And gradings of hypovolemic loss. Based upon the loss of fluid, it is graded into grade 1, grade 2, grade 3, grade 4. That is less than 15%, 15 to 30%, 30 to 40%, more than 40%. 15%, this is raw. Yeah, 15 to 30 here, 15 to 30, 30 to 40, more than 40. These are the grades. So grade 1, these things are not necessary for at present in your semester. Remember, grades of hypomolic shock, grade 1 it is less than 50% loss. Grade 2 15 to 30%. Remember, 15 to 30%. Grade 3 30 to 40%. Grade 4 more than 40%. Yeah. Yeah, see, this is very, very important. This is directly taken from the Bailey. See, class 1, class 2, class 3, class 4. Blood loss 0 to 5 less than 15%, 15 to 30%, 30 to 40%, more than 40%. Remember, blood pressure, urine output will try to this. Remember these two things: blood pressure and urine output will try to alter only from grade 3. See, remember, blood pressure is normal in 1 and 2, decreases from 3. Urine output is normal in 1 and 2, decreases from 3. So these things are very, very important. They lost very frequently. Blood pressure and urine output starts decreasing from which grade of hemorrhagic shock? In grade 3, that is 30 to 40% of fluid loss. Next type of shock from the mnemonic I told you, code CODE, cardiogenic, obstructive, distributive, endocrine shock. So first is cardiogenic. Cardiogenic is nothing but primary failure of the heart to pump the blood. It is because of myocardial depression. It could be because of either endogenous factors or exogenous factors. Endogenous factors are because of bacterial agents. Exogenous factors are because of drugs. Causes are myocardial infarction, cardiac arrhythmias, valvular heart disease, vent cardiac injury, cardiac myopathies. Next, mnemonic, according to mnemonic code O for obstructive talk. It is nothing but obstruction of the outflow. Remember, see, there is a decrease in preload to the organs because of obstruction to the blood flow from the heart. It may occur because of cardiac tamponade, tension pneumothorax, or pulmonary embolus. Next, distributed shock. There are three types of shock coming under distributed shock. That is nothing but septic shock, anaphylactic shock, or spinal cord injury. See, this is very, very different from all other types of shock. I will be explaining further. Inadequate organ perfusion accompanied by vasodilatation with hypotension, low systemic vascular resistance, and inadequate afterload. Anaphylactic shock, vasodilatation. See, basically the pathophysiology is same. Whereas the causes for septic shock, anaphylactic shock, and spinal cord injury is different. Septic shock, it is because of bacteria. Anaphylaxis because of histamine. See, the cause for anaphylactic shock is because of histamine release. Whereas neurogenic shock, it is because of spinal cord injury, there will be failure of sympathetic cortex. Whereas for septic shock, it is because of bacterial lipopolysaccharide. Coming to definition of septic shock, that is nothing but systemic inflammatory response syndrome. According to this, it defined as these four constitutes septic shock. I mean, SIDS, heart rate more than 90, WBC count more than 12,000 or less than 4,000, temperature more than 38 or less than 36, respiratory rate more than 20. So these are the important definitions. You must by heart at least. When there is systemic inflammatory response syndrome, that is SIDS. These are the definition of SIDS. If there is SIDS and documented infection in the body, then patient can be termed as sepsis. If the patient has got sepsis and the patient has got associated hypotension, then it comes under septic shock. Okay. Coming to last type of shock is endocrine shock. It may be present as combination of other types of shock, that is hypovolemic shock, cardiogenic shock, or distributive shock. So what are the causes of endocrine shock? It is called as hypothyroidism, hyperthyroidism, and adrenal insufficiency. These are the types of endocrine shock. So you must read the consequences of shock. What are the consequences of shock? If patient undergoes consequences, what are the consequences that occurs in our body? So initially there will be a phase of compensation. It is called as compensated shock. Then there will be a patient of decompensated shock. So coming to compensated shock, there will be decreased blood flow to non-essential organs, mainly like skin. So there will be decrease of and gut. So there will be decrease of blood flow to non-essential organs by for brain and lungs. There is a acute hypoperfusion occurring at the tissue level. On prolonged state of hypoperfusion, it will lead to multi-organ failure. Patient with more than 12 hours of acute hypoperfusion has got higher mortality. Decompensated shock. What is happening in decompensated shock? If there is prolonged loss of fluid, the body loses its compensatory mechanism at a certain stage. So loss of around 15% of blood is within the compensatory limits. I told you, blood pressure is maintained well till grade 2, and it will starts to fall only in the grade 3. That is only after 30 to 40% of the blood is lost. I told you previously, this is the state. Coming to severity of the shock. Severity of the shock, it is classified into mild, moderate, and severe shock. This is the table. This is taken from Bailey and Law. So remember, compensated shock, decompensated in which mild, moderate, severe type of shock. Remember here also again, I am telling you again and again, blood pressure is starting in moderate type of shock or grade 3 of hypovolemic shock. This is very, very important. Coming to resuscitation. How are you going to resuscitate a patient with shock? So the time of starting of resuscitation is very, very important. Immediate resuscitation is done to ensure patient airway, oxygenation, circulation, and ventilation. Conduct of resuscitation. How you are going to conduct resuscitation? So we have to know the type of shock and we have to treat according to it. So assessment of type of shock should be done. If there is initial doubt that we don't know what is the type of shock, consider all types of shock to be as hypovolemic shock and treat according to it. In case of hemorrhage, there is no use of fluid therapy without stopping of bleeding. Care should be taken on fluid therapy as increase in blood pressure increases the bleeding therapy. So then comes the concept of coagulation factors also gets diluted, further increasing bleeding, dilution, coagulopathy. So this is the concept in fluid therapy. In all causes of shock, initially hypovolemia should be addressed and provide adequate preload. As administration of inotropes to empty heart with further deplete oxygen level may end up in unresuscitative state. So we have to put the patient on short, wide bore catheters than long, narrow bore catheters like central lines. So what are the type of fluids? Ideal fluid of choice is crystalloids, then colloids and blood proteins. This you people must be knowing by now, which will be discussed in medicine class. Crystalloids, isotonic, 0.9% NS, Ringer lactate, isolate. Hypertonic, 5% dextrose. Hypertonic, DNS, 3% NS, and Darrows solution. Hypertonic solution are poor volume expanders and should be used only in patients with sodium overload, like free water loss or sodium overload, like in patients with, remember, two causes for hypertonic solution infusion: cirrhosis, diabetes insipidus, where there will be patient with free water loss and sodium overload. Coming to colloids, colloids increases oncotic pressure in intravascular system and draws water from extravascular system. So colloids are contraindicated in shock because this will leads to further increase precipitation of the shock. In shock, there is damage to endothelium due to which there is chance of escape of colloid from intravascular system to extravascular system. So it will, when it goes to extravascular system, it will draw the fluid, which leads to further increasing edema, which will exacerbate the hypoxia. So in case of shock, endothelium will take 12 to 24 hours for its recovery. So whenever you want to plan for colloid infusion, it should be considered only after 24 hours. Types of colloids are recombinant human albumin, dextran, heme seed, and starch. Blood and its product, whole blood, FFP, PRBC, platelet, and cryoprecipitate. Coming to fluid response. Generally, around 250 to 500 ml of fluid is rapidly given over 5 to 10 minutes and will assess cardiovascular response and graded into responders, transient responders, and non-responders. Responders, there will be improvement after a fluid infusion. This indicates there is no active fluid. Transient responders, when you give treatment, they will show improvement, but within 20 minutes, the again will starts to fall down. Those are transient responders. This indicates there is moderate ongoing loss. Another category is non-responders, where how much ever you do resuscitation, the patient will not respond because there is a severe ongoing blood loss. Vasopressors and inotropes. These are not first line of treatment in hypovolemic shock. So what are the agents to be used are phenylephrine, noradrenaline, and important inotrope used in cardiogenic shock is dobutamine. Remember, vasopressor and inotropes used are phenylephrine, noradrenaline, and dobutamine. Monitoring. What are the parameters we need to monitor in a patient with shock while resuscitation are heart rate, BP, SpO2, urine output are minimum standards, out of which very important is urine output. It will show the response of treatment given to a patient with shock. CVS, ECG, oxygen saturation, pulse waveform, and blood pressure. Systemic and organ perfusion. Best measure of organ perfusion and best monitor of adequacy of shock therapy is, I told you, best measure of organ perfusion and best monitor of adequacy of shock therapy is urine output. This is the best measure. Cerebral perfusion, level of consciousness can be assessed, but we cannot rely on it. GA and muscular beds based upon lactic and base deficit, mixed venous oxygen saturation. But best among all the things for organ perfusion and monitoring is urine output. Mixed venous saturation, this is again a very important concept. Normal is 50 to 70%. If the patient has got less than 50% mixed venous saturation, it indicates inadequate O2 delivery. If it has got more than 70%, that means it is mixed venous saturation is nothing but taking off reverse of venous oxygenation saturation, which is returning to the blood, which is returning to the heart. Why in sepsis it is more than 70%? Remember, in shock, it is due to disordered utilization of oxygen at cellular level and AV shunting of blood at microvascular level in septic shock. So where the cell will not take the oxygen, so this oxygen will return back to the heart, which is more than 70%. So there is more than 70% of mixed venous oxygen saturation seen in case of septic type of distributive shock. Then other methods for monitoring tissue perfusion and oxygenation are muscle tissue oxygen probes, near infrared spectroscopy, sublingual capnometry. Thank you.